Hello everyone, I'm Bronwyn Williams and I was previously the coordinator of the Eastern Mental Health Service Coordination Alliance and additionally I was the NDIS program lead for Eastern Health's mental health program. Firstly, I would like to acknowledge the traditional custodians of the land on which you're meeting today and on which I am today, and I pay my respects to Aboriginal elders past and present and any emerging leaders. I also pay respect to Aboriginal and Torres Strait Islander people joining here today and acknowledge that their sovereignty has never been ceded. And today I just want to recognise the knowledge and wisdom of those people who have a lived and living experience of mental ill health and psychological distress, their supporters and the practitioners who work with them. They make a significant contribution to the development and delivery of health and community services. So this is the alliance that I was coordinating for the past 10 years. This alliance existed before I took over the coordination function in 2012. And it emerged about 15 years ago out of a collaborative work between tertiary mental health and community mental health providers. The alliance expanded to include AOD, family services and homelessness housing in around 2010, and then the alliance further expanded to include primary health and various other sectors so we could achieve a broad representation of all local health and community services. And the vision of the alliance is for people who experience mental ill health and co-occurring concerns and the people who support them to access responsive, appropriate and collaborative services to assist with the multiple facets of their individual recovery journey. And I'm sure for you guys here in Goulburn, you have a similar vision for your services to work more collaboratively. So shared care, that's the subject for today. What is shared care? It refers to obviously the process by which one or more agencies or programs work together with a particular consumer in order to facilitate an appropriate, collaborative, consistent and coordinated service delivery. Shared care, collaboration and integration are key aspects of health policy and they're central to the work of our alliance, and I'm sure that is central to yours too. The aim of shared care is to reduce the burden to the person in coordinating the various providers themselves, and it reduces how often they need to tell their story over and over. It reduces the incidence of having similar treatment and support provided by a range of staff, and it utilises the person's time more effectively. Similar benefits of shared care are available to staff. They can be clear about their role, they gather important and useful information more readily. It reduces their workload as they share tasks across organisations and helps them be alert to broader issues, including safety concerns. So EMHSCA, as part of the EMHSCA work, did a really large research project to look at what supports and what disrupts the provision of coordinated care for people, particularly with mental health issues and co-occurring concerns in our region. And these recommendations emerged from interviews with 59 local staff, leaders, consumers and carers. We're focused on what we can change at EMHSCA, and the recommendations include improved service navigation, standardised worker knowledge across sectors. So workers in various parts of the service provision have similar levels of knowledge and skill. A stable workforce that's, the faces aren't changing every second day. And these things all featured very strongly across all study cohorts. Consumers told us that they need a gentler approach, and that was really important for them to enable them to collaborate. We also learned from our study that carers often feel left out of the care team. And this is the model that emerged from the research. This model of care coordination will be very familiar to some people, with obviously the consumer at the centre of the care. As qualitative research, this model came out of a detailed analysis of themes from participant interviews across all of the cohorts, so 10 consumers, 10 carers, 19 staff, 4 lived experience workers and 16 leaders, all provided their advice, and it's all summarised here. So the model depicts the relationship between the various key components of care coordination, and it all starts with the person at the centre of the care. When the person is central, the care team are well engaged, their individual needs are respected, and the composition of the care team is easier to define. The second circle, the human touch, is the needed connection between the person and the care team. Trauma is so very common for people accessing supports. And consumers say they need a gentler approach to care that acknowledges the trauma base, and a less stimulating environments reduce their anxiety. Lived experience workers provide understanding, and many people said these workers were easier to trust and work with. In fact, one of the interviewees said that lived experience workers are gold. Point 3, which is the third circle here, sharing and owning the importance of teamwork. The key characteristics of teamwork were described by staff and leaders in particular, and there's a significant overlap of consumer characteristics across all the service sectors. So you'll find that in your alliance too. A joined up approach can provide a more holistic response for people who are across multiple services. Consumers said they don't like having to repeat their story, as it can be re-traumatising. So when their supports are working together, roles are clarified, mutual respect is engendered, safety issues can be managed, and people receive better continuity of care. Having just one care plan was also mentioned by a number of people as being useful. Services need to coordinate to enable this to happen. Many participants identified the importance of having someone assigned to coordinate the care when the person is unable or not wanting to do so. The next circle is the importance of connections and networks, and we have found in our region that networking staff is an essential component to the Alliance. We network people at multiple levels, so we have obviously a coalface alliance, which we call our linkages, where service providers meet and go around from service to service to understand what the various services do, and really have that face-to-face connection. So when they do a referral, it is a very warm referral. So network meetings, cross-sector training is really important. We do a lot of that with the Alliance. And leadership partnerships all contribute to better support pathways and more integrated care. So if you haven't already considered a local linkage, it's a good time to join. And the fifth point is the importance of resourcing. So proper resourcing for collaborative care is important and often lacking. Consumers report that when staff are busy and task-focused, they're just not getting the support they need. And that human touch, which is so essential to the connections in a care team, gets lost. A stable support and well-resourced workforce can provide the continuity and integration of support required to enable recovery. The key barriers they identified, you can see in those arrows pointing in, were service navigation, people finding it really hard to navigate to the supports they need, stigmatisation, and that happened across all the cohorts, so not just for consumers and carers, but also for staff across sectors. Inflexible models of funding, such as fee for service, and we've seen this with the NDIS. It's more difficult to collaborate and coordinate under NDIS because it's a fee for service model. Similarly with GPs and psychologists in the community, it can be very difficult to get them to come to care team meetings. And power imbalance. Now we know that, you have the hierarchical structure of the tertiary mental health service provision, and then you have a whole range of supports that often feel that they're not able to intersect because of those power imbalances. Power imbalances also exist for consumers and carers, as you know. And these are very disruptive to our efforts to work as a coordinated care team. So we need to work to address all of these barriers going forward. So some of the challenges to shared care that we have gathered over many years. So we hold these collaborative care planning workshops for the last 11 years. And we've been gathering these challenges every year. So challenges that have been expressed through these, I've just summarised here on the slide. So workforce limitations and time constraints, funding models, staff willingness, communication was a big one, being able to have clear communication mechanisms that work. When people respond, that's great, but they don't always respond. Knowing who's involved in the care team, really important, and sometimes that's a consent issue. Knowledge and skills is really essential, that we have the understanding of the sectors, and we have enough knowledge of how to screen for various needs, particularly around substance use, gambling and those sort of things, and being able to navigate to the right supports when we do find information. Service access barriers and a lack of availability of supports, such as, short-term engagement with consumers for some service providers and longer-term engagement for others. Systemic hierarchies, worker traumatisation and stigmatisation were all mentioned as challenges to shared care. In our region, we initiated a shared care protocol many years ago. It's been around, since about 2007. It was first delivered to community and clinical mental health. So it was really about, okay, we've got the tertiary mental health system, we've got the community providers, let's get them to work together. So this shared care protocol that you now have the ability to implement in your own region has been developed over a very long period of time. And over time, we added in other providers to the shared care protocol and we reshaped it. We had a committee that sat over a number of years called the Collaborative Care Planning Committee. And that committee actually kept reviewing the protocol in relation to the various sector members joining. So the existing protocol includes family violence and Aboriginal and Torres Strait Islander people. It's really very inclusive now over time. So the protocol includes guidelines on the collaborative practices for service providers when they work together with shared consumers, for the development of shared care plans, and for appropriate and effective sharing of information between the parties to the shared care plan. It's also for supporting effective transitions of care and support. And there are a series of references and flowcharts to support the protocol. There's a story woven throughout the protocol of Jamie, and that helps us to better understand how the protocol can be applied. These shared care practices are also really integral to the shared care protocol, and this is what we deliver in our training. These took a really long time to develop into 5 key practices. I think we started with about 15, but we've honed them down over the years, and we've had lived experience involved all the way along the journey too, just to let you know. So we've had lived experience participants in all the various committees to develop these practices. Many of the staff from a variety of sectors ask, how can I initiate a shared care arrangement? And the key to the shared care protocol are these 5 practices. So the first thing to do is initiate a conversation with the consumer about who is supporting them, find out who's involved. And then the second point is seeking their consent to make contact with other providers as appropriate. And then it's important to gain a longitudinal history where possible to save the person retelling all of their story. Find out who the person's best engaged with and see if they're willing and able to coordinate the person's care. Also, ask the person if they would like to coordinate, as some people prefer to do this themselves if they've got, a lot of agency. Involve carers as appropriate, remembering they are often the most consistent support in a person's life, and particularly if the person's living with them. Consent isn't always an issue, and if somebody has a carer involved and they say, no, I don't want you to talk to my mum or don't want you to talk to my relative, it's really important to just delve a little bit deeper and find out why, but also remind the person that you have got a responsibility to support their carer. It doesn't mean that you'll convey any sensitive information in that process. Keep the person's goals at the forefront of the support work and include the family and carer wherever possible. Okay, and then a template was developed for individual recovery planning, which you might have your own. These are the key principles of our recovery plan tool. So the plan owner's strengths and resilience factors need to be included. We need to list all the key supports. Consent is given by the plan owner for and the plan owner obviously is the consumer, that they need to consent to the various partners being involved in their recovery. And suitable methods of communication between supports need to be clarified. A planning coordinator is really important, and it may be anybody in the care team. It could be the consumer themselves, as I said before, but it might be their alcohol and other drug worker It might not be the mental health case manager. So being open to selecting a planning coordinator that works for the person. And usually the person they're best connected to is my recommendation. That the person's goals are clearly articulated and that they're really achievable goals, so SMART goals, things that they might want to work towards in the very short term, and try and restrict them to, 3 to 5 goals with some clear outcomes. The roles of the various support people are clarified in the plan and regular review times are set up, and that progress is monitored and communicated amongst the care team. I'm in a care team right now for somebody with complex support needs, and it's really essential because we're getting a lot of communication going on, that everybody is included in that communication in the care team as appropriate. Just to acknowledge that most services have their own templates for care planning, but we really recommend that you bring those templates together if you've got multiple services involved, and that the consumer has a say in which template they prefer, so that they're not just being foisted 5 templates by various service providers, but that you hone it down to one just for them. It's fine to keep your own locally, but it's important that the consumer's not confused by multiple templates. If you'd like to see more information about the various tools and the work we've done, there's plenty of recordings online at the EMHSCA webpage, which is located at the Eastern Melbourne PHN webpage. I'll forward you a copy of these slides and you'll have my information if you have any further questions. I hope you really enjoy your workshop today, and I hope one day to meet you all. Thank you.